Okay. Good morning. I will talk today about cardiovascular disease and risk management standards care in diabetes 2024. First of all, we assess the risk of the patient by non-modifiable risk, modifiable and lifestyle. Okay. Assess the non-modifiable risk and modifiable ask about the lifestyle of the patient, smoking, diet, exercise, and stress. Also assess the social life of the patient by income, social deprivation, and environment. We should to assess the hyperglycemia, the hypertension, weight gain and obesity, oxidative stress, physical inactivity, diet, endothelial dysfunction, insulin resistance, inflammation, dyslipidemia, hypercoagulability, and the activation of the RAS system. Second, to modify the lifestyle of the patient. To ask him to get healthy diet, morning walk, reduce the stress, get good sleeping, cut the fat and the fast food, avoid alcohol. Then manage the medication of the patient by reduction the diabetic complication, glycemic management, blood pressure management, lipid management, and agents for cardiovascular disease and chronic kidney disease. Blood pressure should be measured in every visit to the clinic. Routine clinical visits should we measure the blood pressure. Blood pressure, hypertension is defined when the blood pressure systolic more than 130 and diastolic is 80 or more than 80 millimeter mercury. But if the patient has blood pressure more than 180 over 110, we diagnose him by single visit. All people with hypertension and diabetes should be counseled to monitor their blood pressure at home after education them. Initial blood pressure, if the blood pressure between 130 to 150 as a systole, start life modification to the patient and give one agent. If he has albuminuria, you can start with ACE inhibitor, but if he has not, you can choose any one of the medications. But if the patient has blood pressure 150 over 90 or more, manage the lifestyle and give two agents. If he has albuminuria, start with ACE or ARBs. If there is no, plus another medication, calcium channel blocker or diabetic. If he has not albuminuria, you can choose 2 of 3 medications. The goal for blood pressure to be less than 130 over 80 millimeter mercury. Treatment with hypertension should include drug classes, but ACE inhibitor and ARBs are recommended as a first-line therapy. For the people with diabetes mellitus and hypertension, and he is in early-stage hypertension, we share decision-making process that address the cardiovascular and potential adverse effect of antihypertensive, what the patient prefer to take antihypertensive. The only treatment target, we said less than 130 over 80. Second, about lipid management. In brief, for people with pre-diabetes and diabetes not on lipid-lowering therapy, check a diagnosis at least annually thereafter. Check the lipid at initiation of the medication 4 to 12 weeks after initiation or after dose change, and annually thereafter. If we will use high intensity, we will use high intensity statin, we use atorvastatin or rosuvastatin. But if we use moderate intensity statin, we can choose any one of these. In summary, for the lipid management, primary prevention of atherosclerosis, if the patient in age group less than 40, between 20 to 40, first start with lifestyle therapy, then consider a statin therapy if he has atherosclerotic cardiovascular disease risk factor. In people aged between 40 and 75, lifestyle therapy is mandatory, then use moderate if he has not atherosclerotic cardiovascular disease. If he has, you can, if he has atherosclerotic risk factor, you can use a high intensity statin. For the people more than 75, continue the current statin or get the benefit risk ratio for the patient. In secondary prevention, the same lifestyle, use high intensity statin to reduce the LDL more than 50% of the baseline or to reach to less than 55 milligram per deciliter. You can add ezetimibe or PCSK9 inhibitor to get the target of the LDL. Treatment at stage B heart failure in patient with diabetes mellitus. زي ما تكلم الدكتور أحمد العنسي على موضوع الهايبر هارت فيلير، في معنا اللي بنعطي الايس انهبيتور او اربس مع بيتا بلوكر، هذا في حالات الستيج بي heart failure. If the patient has high risk or established cardiovascular disease, we add sodium glucose transport inhibitor. But if he has diabetic kidney disease, we add finerenone. Then we add a sodium glucose transport inhibitor. For what? To reduce the risk of heart failure hospitalization. So, in patient with type 2 diabetes mellitus, established atherosclerotic cardiovascular disease, has multiple, or diabetic kidney disease, we add sodium glucose transport inhibitor with demonstration cardiovascular benefit to reduce the risk measure adverse cardiac effect. In patient with type 2 diabetes mellitus, established atherosclerotic cardiovascular disease, we add glucagon-like peptide 1 receptor agonist with demonstration cardiovascular benefit to reduce the risk of major cardiovascular disease. So the sodium glucose transport inhibitor has a benefit in patient population, so recommended to improve symptoms, physical limitations, and quality of life. In patient with type 2 diabetes with chronic kidney disease, we add finerenone. In patient with diabetes and atherosclerotic cardiovascular risk factor, we prefer to give him ACE inhibitor or ARBs. Individuals with diabetes with asymptomatic stage B heart failure, we get interprofessional approach to optimize the guideline-directed medical therapy with the cardiac doctor. Combination of aspirin with rivaroxaban, we give it to the patient if he has stable coronary disease or peripheral artery disease and has low risk of bleeding. But if the patient has a risk of bleeding, we get the benefit risk ratio. For screening, we should screen the patient asymptomatic cardiovascular disease for coronary artery disease if he has symptoms, but if he has not, no need. We screen for the heart failure patients to detect if he is in stage B heart failure by request BNB and echo. Peripheral arterial disease, we search for the screen for the peripheral artery disease for any patient more than 50 years or has any microvascular disease or has any organ failure. Screen by ankle brachial index testing. Also, we screen for coronary kidney disease. For everyone has type 2 diabetes mellitus, everyone has type 2 diabetes mellitus for more than 5 years. We request albumin creatinine ratio and estimate GFR. How often? Annually, but if the patient has late stage, we put it from 1 to 4 times per year. Why we manage chronic kidney disease to decrease the decrease risk of CKD progression and reduce cardiovascular risk. Optimizing the management of glycemia, blood pressure, and lipids can reduce or slow the progression of microvascular complications of diabetes. Patient education and support is very important for diabetic patient. Diabetic education is critical to diabetic management. 1% of the time of the patient spent with healthcare provider, but 99% time of patient spent by himself or herself. Special population like a female, she has risk factors, traditional risk factor for ischemic heart disease, and she has emerging risk factor. Menopause increase the risk of ischemic heart disease. 80% of women who are more than 75 have hypertension. Only 29% have adequate blood pressure control. Diabetes confers 45 higher risk of ischemic heart disease. Obesity confers high risk of ischemic heart disease in women. Women have higher prevalence of inactivity, so 25% of US women get no regular and physical activity, so increase the risk for diabetes and chronic disease. For the special considerations, if the patient has autoimmune disease like SLE or rheumatoid, in SLE, 3-fold higher risk of ischemic heart disease events. Rheumatoid arthritis elevates the ischemic heart disease risk as much as diabetes. Gestational diabetes increase 4-fold. Hypertension in pregnancy increase 3-fold higher risk of ischemic heart disease. And early menopause confers 4.5 times higher risk of ischemic heart disease. Depression is more prevalent in patients, double the risk of ischemic heart disease. So the female is more.
معك دقيقة زيادة.
آخر شيء. Emerging technology. Now we have telemedicine, smart insulin pumps, and remote patient monitoring. And we have a smartwatch to detect heart rate, blood pressure, activity, saturation, and respiratory rate, and quality of sleep. As a conclusion, promote healthy diets, regular physical activity, and weight management are strategies to reduce the cardiovascular risk. Implement guidelines directed medical therapy, including statins and antihypertensive for high-risk individuals alongside personal diabetes management, regular follow-up care, and patient education to ensure adherence to treatment and awareness of symptoms. Thank you.
وننتقل الآن إلى المشاركة الخارجية.